So it's my pleasure to present the update on Checkmate 142. As you know, this is a multi-cohort phase 2 clinical trial study design. Previously, the combination of Nivolumab and ipilimumab in a low dose were reported to be highly effective in previously refractory metastatic MSI-high colorectal cancer. Response rates were reported at 55% for the combination and 31% for the monotherapy. The median time duration was not reached, even not the median time for PFS and overall survival, but the 12-month rate was 77% and 83% respectively. These data led to the accelerated approval of Nivolumab alone or in combination with ipilimumab for patients with refractory metastatic colon cancer following treatment with fluoropyrimidines, oxaliplatin, and irinotecan. I had the pleasure to report for the first time a combination of Nivolumab and ipilimumab in first-line untreated metastatic MSI-high metastatic colorectal cancer patients. We saw in our patient population that the overall response rate, the endpoint of the study, was 60%. 7% of them had a complete response. Interestingly, the disease control rate was 84%, and it was defined at least stable disease after 12 weeks of treatment. So high efficacy data. Since there was a difference in the ipilimumab dosing from the refractory cohort compared to the first-line cohort, where IPI was given only every 6 weeks and not every 3 weeks, we saw significant less toxicity. Grade 3 and Grade 4 toxicity previously were reported at 32%. In this study, only 16%. In fact, the reason for discontinuing treatment for treatment-related effects was 7%, the same than for Nivolumab monotherapy. So we know that the median progression-free survival and the median overall survival have not been reached, but the 12-month rate for PFS is 77% and for overall survival 84%. And the Kaplan-Meier curves are flat at that level, indicating probably ongoing response and long-term survival. The median time to response have also not reached. We actually have the median time to response is 2.6 months. So the majority of responses happen in the first 3 months. There are outliers. So some patients have a late response after 48 or 60 weeks. So watch out for these patients when you treat with immunotherapies. So in conclusion, this new combination of IP dosing 1 milligrams every 6 weeks with Nivolumab at 3 milligrams showed incredible, robust response rate with durable responses, with very promising 12-month rate of PFS with 77% and overall survival of 84%. I think this will reflect a new treatment options for this patient population, because you need to remember MSI-high metastatic disease have a poor prognosis. The usually median progression-free survival is 7 months, and the median overall survival between 15 and 20 months. They are poorly prognostic. Seeing this data obviously is very encouraging, and hopefully will get approved in the near future that we can use it for our patients. So since MSI-high tumors are only 5%, it's a very small subgroup, and it's great benefit for them. Unfortunately, for the majority of patients who are microsatellite stable, we have not seen or experienced any immunocombination with clinical success. We have seen the IMPLACE study in World GI in Barcelona, and we heard today in the maintenance setting, the module trial with bevacizumab and atezo did not have any significant benefit. So I think we're still struggling very significantly in the way how we treat microsatellite tumors, which we consider cold tumors, in order to really increase the immunogenicity in these tumors. Unfortunately, MEK inhibition in the IMPLACE trial was not sufficient. I think we need to be much more innovative in combination of different targeting the effector cells, the T cells, the NK cells, the tumor microenvironment, the tumor-associated macrophages, in order to be more successful in MSS tumors. So I think in the future plan, the question is, will this data be enough for regulatory agency to approve it? I'm sure that the BMS team will start discussion with FDA, but we know that Keynote study will come out, which is first-line Pembro versus chemotherapy. I think that will give us even more munition and data to show how successful immunocheckpoint inhibition in first-line is. Personally, I have no doubt immunotreatments will move into first line for MSI-high tumors. For MSS, we need to learn much more. We just don't know enough in order to have the regulation of the whole immune regulatory cells in the tumors as well as in the environment of these tumors in order to be successful in interfering and modulating the potential immune response with drug combinations.